do not have a place. India has the highest oral cancers. Patients are dying early and painfully. 60% of patients who visit cancer hospitals have tobacco addictions. Tobacco is a disease, needs treatment, not quackery. I underscore that please, that it is a disease, it needs a treatment, it needs a proper intervention like any other disease, right? Nicotine has the greatest addiction. Outcome of patients compromised for the present treatment. For whatever the reason that patient might have gone to the hospital, maybe it cardiology, pulmonology, oncology, or whatever, it is compromised if we are not addressing this issue of tobacco cessation. The secondary prevention, yes, of course, it is there, so that we avoid the second disease. And we have seen in our hospital, in my practice, a lot of patients who have undergone cardiac, the stenting and other things, but they come back with cancer after maybe 4 years, 5 years, because they did not stop tobacco. Oncology treatment, where oral care is a must. Yeah, wherever we have the oncology treatment, oncology hospital, oral care is a must. So this is just some of the experience that we started. I first set up a tobacco cessation center at Noida and at Muradabad, and both of them, it was a standalone TCC center, and it was a failure. This is what my learning was, and it needed something, it needed some value addition, and that is what we understood. So this, the innovation was that how we created a difference. This is what we learned. The solution was required. The TCC initially, all the money, every effort was gone, and then was born the Save the Youth campaign, which we were already doing it, but we started working extra on that. And that is, if you look at the full scope of the Save campaign, S is for sensitization, A is for assistance to how to quit tobacco, T is for volunteer training. That is, we started training the people around us, and I'll tell you about that, and enforcing tobacco-free zones at every place. So sensitization in 3 things: be smart, do not start, we know what tobacco is, easy, and be careful and fearful. And this is what we started, the ambassador, the certificate courses. And I was glad that we, after a long struggle, with the help of Dr. Rakesh, we could be, our courses was accredited by Gujarat University, which was a feather on our cap. And we started working across India to empower people, to train people in tobacco cessation. So this was the orientation course, the certified tobacco cessation specialist course, and of course the tobacco marshal courses that we started for the public. And this is another thing that we started looking. If you look at this, the skill gap, there was a lot of the students, the dental students who needed to understand tobacco cessation. There was a huge skill gap, the oral care, the tobacco cessation. So we started the skill up workshops, and that is what for students and professionals to bridge the missing gaps. And we are doing this extensively, and we are approaching the dental hospitals to have this skill up workshops. And we have also started this online program that is a skill up capsules that we are also launching very soon. So this is one of the skill up programs that we started online, and this is with one of the college at I think Bangalore. So what the solution is that we need to have centers available across the country, skilled specialists for TCC and early diagnosis and intervention for oral cancers. And this is what is required. Every corner, every place, it should be skilled tobacco cessation specialist, and they should be doubling up for oral care as well and oral screening. And this is what we started, and this we set up at Max as a pilot project. I was glad, and the Max authority gave us the go ahead to set up a center at Max, and we started the 6 things in this program: the oral screening, oral prophylaxis, oral rehabilitation, tobacco cessation, community networking, diagnosis and treatment of the PML, the pre-malignant lesions. We also started working in that. So this created a full aura, a full system that we could take it further. And there was some, actually the most important, as Dr. Kaustubh had also said, that we need funds. Yes, and I have no funding for this matter. So we needed to create funds from our centers itself. And this, putting all these things together, we have been able to run it successfully. And now it is almost 1 year. We are doing it in a very well-defined manner. So assistance tobacco cessation program, this is what we started working. We launched the virtual clinic, and we have now 108 doctors who are trained on our virtual centers, on a virtual platform, who can perform virtual tobacco cessation across India in multiple languages. We started a telephone and a WhatsApp system with the Quit Coach intervention. we had this pharmacy. A lot of medications which are required for tobacco cessation may not be available at the house of the patient. So we started this e-care pharmacy so that we will make it available at the center. And then we kept this book, which was there for the patients, that win over tobacco made easy. And of course, we started the quit line number, that is the 011 430 77695, which was a number for anyone across India. Just can call this number, and we have trained people who can help and assist them to quit tobacco. And most importantly, we introduced an ICanCaRe app, which is the world's first app which is dealing only on tobacco cessation. So what we started lately is to build up to start up the centers. Actually, there was a very major thing that was a skill gap. We had a lot of manpower was required, and then training the people across India, across the dental professions, and that is where we started the Oral Oncology Connect program, a well-designed program for dental specialists. So this is what we started. The OOC CME programs, which was a standalone program. Can you keep that slide, please, Shruti? Yeah, so OC CME program, that is different idea groups we have started. We have done at Moradabad, Bulandshahr, Aligarh. We have done at almost 8 or 10 ideas we have already done with that. So this was another thing that we started. We started the roundtable meets with oral specialists and oncologists exclusively, inclusive. The oral care, the dental people, and the oncologists we started. And this was a very important roundtable meet when we exchange ideas, we exchange cases, and we started building up on our understanding. So we want to start this case capsules every monthly. I'm sure after this program, we will have more and more people joining it to start this case capsules. Since it will be online, we can have everyone across India. We are looking for workshops, hands-on training, how to do biopsies, what are the various ways, so that the suturing and other things. So this is the thing that we are in the way, and we are planning to start this in the month of June. Tobacco courses, of course, OCTC and CTCS, Gujarat University, a lot of people are now looking for that. And we have this 2 E-Conclave every year, that is the month of April, the oral E-Conclave, and a tobacco con in July, which is just coming up. And I'm sure this tobacco con, this is the only such conference which is dealing with tobacco cessation. We are not talking about tobacco control, we're talking of tobacco cessation. Oral cancer information on the screening app, the internship programs we have started, the oral care and screening and tobacco cessation centers, which are ICanCaRe powered. We are looking forward to set up such centers, upgrade the existing centers across India. Camps and workshops with oral specialists to reach out to the public, and IC material sharing. Yes, these are the things we are already into it. I'll just quickly go through it. I'm sure Shruti is running the slide because I'm taking extra time. So OOC RTM East Delhi, that is what we did, the roundtable discussions, roundtable meet, and you can see a mix of oncologists and dental surgeons. Next, please. Now you can run the slide, Shruti. So faculty at RTM, mix of onco and dental specialists, exchange of ideas and inclusion. And here you will see the dental specialists are here, the prosthodontists, the pathologists, oral pathologists, the oral cares, and so everyone was there, and we were the oncologists sitting here and talking to them, learning from them. And this is another RTM we started, and the Oral Oncology Connect program. So this is how we have started, and we are working across, and we started this as an Oral Oncology Connect across India. Anyone can register, and we are working on that. And this is another program, the Community Connect program. That is what we started. And this is the tobacco marshals. Here you can see this is the cap, and we are giving this, and we have this cap and batches. We train the people across India. They are the influencers in the society. We train them so that they can work in the society for making it happen. So ICanCaRe internship program, that is another thing, short rotation program in Department of Oral Oncology, and get practical feel and learning of diagnosis and small procedures in OPD and OT observations. This is what we started, internship program, and 4 interns have already been trained. And these were the 2 interns with the faculty. Yes, we have already trained 4 of them. So this is again with something that we are working on that. So with this program, we have a lot of intervention, a lot of people are coming in, and you will see that how it is affecting. Just look at this. Any place they would have done a biopsy or removed it. But what I did, once they joined the ICanCaRe, Max ICanCaRe Quit Tobacco program, and look at the way it has disappeared, just with quitting tobacco. We did not have to intervene in these patients. Next. And this is another what I call Vigilant eyes saves life. Here you can see a varicose lesion. It's a very small lesion. In a patient who have been taking tobacco, the mouth opening is decreased. We exercise this and we have given them a mouth opening device. So this is how if rehabilitation, and this was a patient on palliative care who had a tooth abscess and he was in severe pain, but no one was taking care. His oral cavity was almost so dirty. We cleaned it, did some prophylaxis, drained it out, and this patient was so satisfied and so happy after that. And this is another patient who is a basically you can see how they have, she has improved. And
here, since I've come along thousands and thousands of miles from Fiji to here for the treatment of my daughter, and I'm very fortunate. Thank both of you, Mr. Rohit, Mr. Rohit, and as well as Tandy, Dr. Sita. Thank you, my daughter and my doctor, for treating me. So,
yeah.
तेरा मुझसे ऊपर है कनाता कोई उन्हीं नहीं दिल पाता कोई.
So these are some of the patient of physiotherapy, chemotherapy. We had to give him the rehabilitation, and he feels so happy. And next slide, Susti. And this is another patient who needed who has come. I had done a surgery 3 years back. Now he has come for rehabilitation.
म्यांमार से आया हूँ. ये मेरा छोटा भाई है. 3 साल पहले इनका ऑपरेशन हुआ था डॉक्टर पवन गुप्ता से. अभी 3 साल बाद हम लोग वापस आए हैं यहाँ दांत लगाने. डॉक्टर अर्चिता माइक्स हॉस्पिटल में अपना भी हार्ट दिखाया, शुगर दिखाया. एक ही जगह में मेरा सब कुछ हो गया. मेरे को बहुत खुशी हुआ, बहुत अच्छा लगा.
These are some of the success stories, and that is what we said. We need to have a complete community where we can actually tame this tobacco or oral cancers. That is, so these are the 4 pillars. What I say, availability. We need to have available centers available. The doctors should be available. They should be skilled. That is skillability, and it should be sustainable model. We need to improve the skills as they go on. Visibility. This center should be visible, available at all places, at all the hospitals, all onco centers, all cardiac centers, all dental centers. These centers should be visibly available, and networking across the society. And this is how I'm sure with the referrals from the networking, we can make a successful program. And I'm sure over a period of time, we can control this menace of oral cancers. I thank you so much. And these are some of the materials, as Dr. Kaustubh said, we need to have the materials. And this is where we put in our efforts to develop the materials, jot it down, pen it down, and make it into the books so that it can be taken, it can be helped for skilling up for the lot of people across India. And this is the ICanCaRe at a glance. We have got online tobacco cessation 279, sensitized for 689, reached out to 165 children across India, adult sensitized more than 2 lakhs, tobacco patients counseled more than 1,000, cancer rehab products 493, and more than that, cancer patients helped 1,298. That's a number. And we have trained 611 doctors till now, 527 trained across India. Tobacco marshals we have started. This is an old number. I think we have already crossed more than 200. So we are across India, we are working, and we are sure with this whole program that we are running, I'm sure if it is adopted, as Dr. Sathan said, if it is adopted, it can really make a difference, and that is what I believe in. So I leave it to the august audience and all the seniors to judge and take it further to how we can work on it. Thank you so much.
Thank you, Dr. Pawan, for such a live and beautiful presentation and the work which you're doing for humanity. What I gather by this presentation is that an early diagnosis of cancerous or pre-cancerous lesions can save many lives, and to that, dental surgeons can be of great help. And for that matter, you are already promoting so many tobacco cessation centers also. Even I want to add that Dental Council of India has also made it mandatory for all dental colleges to have one tobacco cessation center. But I think if, like what you are talking about, that tobacco cessation specialist, if that be there, which you said already you have more than 100, you have made tobacco cessation specialists all around. if those specialists are there in most of the colleges, in most of the towns, that can be of great help. And even I've seen that for Christmas you have made some equipment that is also very helpful. And I think if all colleges and all dental surgeons or all practitioners for oral cancers, they are able to see that, and that will be of great help to most of the practitioners for oral oncology. Thank you, Dr. Pawan, for the presentation, and it is open for audience for any question.
Thank you so much, sir. I think we can have the questions during the panel discussion.
Yes, yes. So nice.
Thank you so much, sir, for all the inputs. Thank you, sir.
I now welcome Professor Dr. Anil Dcruz. He is president of UICC for the term 2022 and director oncology, Apollo Hospitals. He is ex-director at Tata Memorial Hospital, Mumbai. He's a researcher, administrator, and crusader in the field of cancer control with a special interest in tobacco advocacy. Dr. Dcruz has served on the UICC board of directors for 2 terms, adding value in the membership, governance, and finance committee. Dr. Dcruz served as editor of Manual on Clinical Oncology, a UICC publication, including numerous pivotal contributions in over 500 peer-reviewed publications. He is a staunch supporter of ICanCaRe. I now invite Dr. Dcruz for his presentation on Dethroning the King. Dr. Dcruz, please.
Yes. How do I do this? Okay. Am I seen? Am I heard?
Yes, sir.
Thank you. Thank you, Pawan, Shruti, your entire team for this opportunity to be yet again with you all on this lovely initiative from ICanCaRe. Dr. Agarwal, thank you very much for your kind words of introduction. Before the program started, we were just chit-chatting among the various faculty. And I did share with Pawan and Shruti that maybe we should have more time for discussion rather than me give a lengthy 30 minutes talk. But I would share some thoughts with you. I've tried to be brief and then probably set the stage for a good discussion that another dear friend of mine, Somesh, would lead. So I've been asked to speak on Dethroning the King, the vision for India. I wear 2 hats. I wear a hat as an oncologist. I used to be at the Tata Memorial Hospital. I continue to treat, research, and teach head and neck cancer. And a large part of my work is oral cancer. I also am part of the UICC for the last more than 10 years. For those of you all who don't know, it's the largest NGO committed to the cause of cancer control, and it has members in 172 countries. So it truly is the voice of the civil society for cancer control. What I'm going to share with you all today is my vision both as an oncologist who's been treating this cancer for 30 years, as well as someone who's committed to the cause of cancer control. These figures are not new to this audience. Kostub did run through some of them. Oral cancer is a global problem, but we do have the dubious distinction of having the highest number in our parts of the world. Of the 350,000 new cases, of which half would die every year, more than half these cases are in our parts of the world, that is in Southeast Asia. What are the challenges that we have in treating this oral cancer? And that probably would help us on strategies onto how we could dethrone this king. There are a large number of cases, and these are paradoxically preventable. They come with late presentation. More than 80% are advanced. Therefore, they have a dismal 5-year survival. We can only cure between 20 to 50%, and that too with severe implications on function and cosmesis. There is poor tolerability and affordability to treatment, and truly it is a problem in our country. And I'm not sure whether the title given to this last session on dethroning the king, it may be the king, but it's probably not the right word, because it really is a true troublemaker and not a king, the oral cancer. There are 3 ways, and very simple, by which you can dethrone this king. One is prevent it. The second is early detect it. And Pawan showed some lovely photographs of people whose disease got reverted without him doing anything. So you need to detect them early. And for those unfortunate who get this cancer, we should cure them with correct treatment. That is the only way we would be able to dethrone the king. Prevent, early detect, and cure with correct treatment. Here is data about a year and a half back from our cancer registry program in the country. There is an increasing trend of cancer across all sites and in both sexes, but focus on the middle bullet. Common 5 leading sites are breast, lung, mouth, cervix, and tongue. So of the 5 leading sites in our country, 2 are within the oral cavity, just to tell you the magnitude of the problem. And why is this so? Because tobacco is a socially accepted custom in our country. We live with tobacco, and tobacco forms an integral part of our lifestyle among our countrymen. The photograph on the right upper corner is a little kiosk bang opposite the Tata Memorial Hospital, and it's sandwiched between 2 pharmaceutical shops, chemist shops, just to tell you how integral tobacco is in our country. And the photograph on the bottom right is a product that is available at one of these chemists, and that is creamy snuff, which is tobacco toothpaste that people use to brush their teeth with, in the belief that they're doing good, without knowing that the harmful effects could cause cancer. Here is global adult tobacco survey data. 266.8 million of our countrymen are current tobacco users, and a substantial number have been exposed to secondhand smoke. Look at this panel on the left side. 42.4%, that's more than a third, a little less than half of our countrymen 15 years and above use tobacco. Look at these 2 bar graphs to the right of this. You can see that while we do have a high prevalence of smokers, the prevalence of smokeless tobacco is much higher in our country. This is common even among children, adolescents. Between the age group of 13 and 15, about 20%, that's 1 in 5, would use tobacco. And the problem is also with secondhand smoke. Now, this is again continuation of the global adult tobacco survey. The mean age at initiation of tobacco is 18.7 years. That means if you are able to target people in schools and colleges, if they don't start till the age of 20, can someone be muted, please? Okay. So if you are able to stop people using before the age of 20, it's unlikely that they will take tobacco. Many of our people who use tobacco, they do want to quit. You can see smokers and smokeless is upwards of 30%, but the success rate is higher in smokers as opposed to smokeless, which is only 5.8%. So we need to control this tobacco menace. 42% of our countrymen use tobacco. They start before the age of 20, and the efforts to quit are more successful in smokers as opposed to smokeless. And smokeless causes a high incidence of oral cancers. So the message is very clear to you all that if you want to dethrone the king, target tobacco and target smokeless tobacco with equal fervor as opposed to smoked tobacco. Government does do a lot of work. We do have advertising is banned on the electronic media, but we see a lot of surrogate advertising, and we need to do something for that. We have heavy taxation on products, but predominantly on the cigarette. Most of our countrymen use the cheaper products of smokeless and the BD. Smoking is banned in public places, but I showed you the high percentage of people who are exposed to second-hand smoke in our country. So we don't enforce laws. Gutka and other products are banned in states. But as I speak to people who manufacture, they just tell me that एक रुपए की पुड़िया 6 में बिकती है. That means the profit making is gone to someone else. We don't have legislation to see and enforce that it doesn't reach the end users. And we do have various organizations working towards the harmful effects of tobacco, education and cessation. Pavan and the ICanCaRe is one such example, but we need very many more people in this field to help in our fight against tobacco. I put the slide up again and again. It's an old slide. It's about a decade old. It's from the WHO bulletin, looking at the policy in 41 countries that could avert smoking attributable deaths. This is predominantly for smoking, but it makes a very compulsive. When you have various interventions that's protect care, offer cessation treatments, warning on packages, enforce marketing bans, and lastly, raising taxes. Raising taxes has the best outcomes in stopping or decreasing tobacco use. Unfortunately, as I said in an earlier slide, most of our financial targets are towards cigarettes. So the finance minister each year will raise the price of cigarette taxes. Precious little is done for the low-end, cheaper products. And if we could target that, we would be able to decrease the consumption of BDs and the chewed products and probably decrease the incidence of oral cancer. Second, early detection and treating correctly. This is not unusual to us. 80% of our workload is like this. How can we tame the king with such advanced tumors? At 2 points in my career, I did a study as to why people come with advanced tumors. The average duration of symptoms was 7 months. 50% of time, the patients were themselves to blame. And sometimes it was because of socio-economic factors. But look, physician factors responsible to delay. Primary physicians was responsible in 50% of cases. The uninitiated treating a pre-malignant lesion, not understanding the implication. The uninitiated who are not head and neck cancer specialists, treating a neck node with tuberculosis and missing and making the patient come with an N3 node. Of course, we do have people who go and treat non-medical personnel as well as alternate medicines in 16% of patients. So if we have to tame the king, we must have the physician factors as well as patient factors to improve. The financial status is linked to the growth and advancement and better living, which is government policy, and it will surely improve. But we can make patients aware, and we can make physicians who are not taught head and neck to be aware of this disease. And what can be better than having data from your own country that good visual examination can save lives? The only trial looking at mortality as an endpoint in oral cancers, nearly 100,000 patients in each arm, randomized to health education plus visual examination of the oral cavity and health education alone. And you can see that mortality is decreased in those who use tobacco and alcohol. When they looked at the whole cohort, it probably did not have an effect. But when you look at the cohort, which are high-risk users of tobacco and alcohol, you can save. So we can tame the king by having effective screening programs. This data was re-looked at a year or so back. And if we don't have the infrastructure to screen the whole country, we can do what is known as risk-based screening. If you screen about 2,000 individuals, you prevent one death. If you screen about 1,029 individuals, you prevent one death across the high-risk group, that is tobacco and alcohol. And if you only screen 610 individuals, at the highest risk, that means those who consume a high proportion of tobacco and alcohol, you will prevent one death. So if we don't have infrastructure to screen the entire country, which is logical, screen the very high risk people, screen people in occupations that use it more, screen people who frequent these shops to buy. They should be enrolled on programs. So the highest risk of individuals needs to be screened to prevent deaths. And we reviewed the literature on risk-based screening, and I wrote a nice Nature Reviews article. It's a prestigious journal. I wrote it with one of my faculty at Tata's, and it's just about a year or two old, that risk-based screening in oral cancers is ideal in resource-constrained settings, like our country, in high income settings when the incidence of cancer is not high. That's oral cancer for the foreigners, and also in times such as COVID, so that you don't have patients, everybody coming to the hospital for screening except the high risk individuals. We need to improve how we can deliver healthcare. Now, generally, we must horizontally grow, that is, strengthen our public health system. But efforts are only in vertical growth. New hospitals are coming up. For example, the hospital in which I work, the Tata Memorial, proudly says we have done 10 new hospitals in the country. But nothing is done for preventive. So if patients come in stage 4 in these 10 new hospitals, you'll still have a 20 to 50% 5-year survival. Something has to be done for the primary health of our patients. While primary health takes a long time to have its effect, a diagonal approach is important. But just making vertical growth, corporates, governments, new aims like hospital without strengthening primary health will not have the desired effect in taming the king. We can do this by a simple hub and spoke model where you have regional cancer centers that do high-end care. You have district cancer control programs, medical colleges and district hospitals that do the normal, not high-end work for oral cancers, and that's for all health. And you have the primary health centers that do awareness, screening, palliative work. They go out into the community. People with lesions come to them earlier. And only with this method will we be able to throne the king. We have a very different mortality to incidence ratio in our country, which is 0.69. That means for every 3 cancers diagnosed, 2 die. Compare it to cancers in the Western world, where out of every 3, only 1 die. And there are multiple factors that has this. If you look at Indian statistics, our mortality rate of cancers doubled in the last decade and a half. So we need to do something. It's also a cause of major financial burden. People have, they're just wiped out when they treat cancers. I've just put a few figures up, but the out-of-pocket expenditure is 3 times higher for private inpatient care in India. Approximately 40% of cancer care costs are met through borrowing, sale of assets, contributions from friends and relatives. Look at this. The last bullet, these costs exceed 20% of the annual per capita household expenditure in 60% of Indian households. So the financial toxicity is a big problem and we have to do something for it. We can improve our outcomes by practicing evidence-based guidelines. Treat correctly. 50% of the patients that I treat are not treated correctly and they have redo. I just showed you the financial toxicity, and now patients come for a second surgery. I did this study in 2013 when I was at Tata's with another fellow of mine, Dr. Mitali, who is now in Patna. If you look at guidelines, you will see now we looked at about 60% of patients who had treatment at the hospital and about 40% who had it elsewhere. The place of treatment was very significantly associated with adherence to guidelines. In working up patients, either place 90% of guidelines were adhered to. So everybody asked for a PET, for a CT, for an MR, for obvious reasons, which all of you all can understand. But when it comes to the treatment, there were deviations, significant deviations in community compared to tertiary cancer care centers. So we must have some sort of legislation that people out in community treat patients correctly. All patients can't come to tertiary care cancer centers. We must strive for specialty practice. An old paper from Berkmeyer, New England Journal of Medicine, early 2000s, it was published, looking at the outcomes of hospital volume, surgeon volume on operative mortalities of 8 common cardiac and oncological procedures, basically advanced procedures. They didn't have head and neck in this, but I've just put it up to make a point. Nearly 500,000 patients. And specialty care was very, very important. The outcomes in a hospital, and please read this last line, that the effect of hospital volume is largely due to surgeon volume. So the point that Pawan is doing in this last session, capacity building, very, very important. Every Tom, Dick and Harry will treat oral cancers. A general ENT, a general oral maxillofacial surgeon without specialized training, and it compromises the success and the outcomes in our patients. So let anybody do it, but let them be trained well and let them have specialty practice. We must do research in our centers. Just treating has no use. Here I put another favorite slide of mine looking at the NHS outcomes in colorectal cancers. Over 200,000 patients treated in the UK. And you can see that centers that had a higher participation in clinical trials had a lower mortality, improved survival, and the longer they were in clinical trials, the better the outcome of their patients. And it's not only patients who are on the trial who benefit. Even patients who are not on trials, but if the doctors are tuned to the concept of research, do well. And that's called a bystander effect. These other patients also benefit. They have improved and rationalized decision making. The institution practices evidence-based practice, and they're always exploring newer treatment regimes and instrumentations. And I proudly present research done by our group, which I led, published in the New England Journal of Medicine, one of the most prestigious journals, just telling us that if you treat the neck in the clinically node negative, you save lives. 1 death is prevented in every 8 patients treated with neck dissection, and 1 recurrence is prevented for every 4 patients treated with the elective neck dissection. This is the first trial from the Tatas that came into the New England Journal of Medicine. It's the first global surgical head and neck trial in the New England Journal of Medicine. And it's today the standard of care and guidelines across US, Europe, and even in our country. Making a point that if you do research, it is possible in our country, and you improve the outcomes of your patients, plus you do public good by contributing and saving lives. Unfortunately, funding is poor in our country. Here again is Paul Gross's paper then from the Lancet, showing the number of trials that are done. You can see our country is very, very low, and the number of cancer trials per 100,000 population probably is the lowest among most countries that do research, and we need to do something for that. If we don't have the money, I can understand public spend is less, and I've not put those figures up, but we can do cost-effective innovations of care. Metronomic chemotherapy, low-cost chemotherapy, but do it in a research mode. Do 6 fractions versus 5 fractions radiotherapy. Altered fractionation improves outcomes. If you treat people 6 days a week, you'll free up the machines faster, and you can increase the number of patients that are on the machine. You'll be able to save more lives. Maybe something exploratory like NACT, neoadjuvant chemotherapy. Give it, decrease the extent of surgery. And our N0 trial, simple trial, just randomizing patients into wide excision of an oral lesion with tongue versus no neck dissection, easily done. So I'm going to conclude sharing a few thoughts that cancer is a global problem. Oral cancer is India's problem, and we have a high explosion of cases. Although we had a national cancer control program since 70s, it's largely remained on paper. Much needs to be done. And we have to have a holistic approach focusing on prevention, screening, treatment, delivery, and equity to make this care affordable to all our countrymen. Then and only then we will be able to tame the tiger or the lion or the king. Thank you once again, Pavan, Shruti, and the whole group for giving me this opportunity to share my thoughts. Thank you very, very much.
Thank you, Dr. Decruz, for the presentation. It was really a privilege to be the audience of this presentation made by you, a great person. Thank you, sir, for your presentation.
Thank you.
I think
I'll take it here then, sir. Thank you so much. So I think we had a great and what a terrific ideas presented by each of the 3 visionaries on the dais. I mean, lot of things to learn, lot of things as a takeaway message for our audience is that, and it's the most important 3 P's, that prevention is something which is done, the early diagnosis, and ensuring that right treatment procedure is followed so that all these cases are tamed in the country properly. So ensuring that both the physicians as well as the patients comply and are educated so that they follow these principles and guidelines to ensure that the right treatment, the right diagnosis and screening is done on time. And so the advanced stages can be prevented. And ultimately, this king, this notorious king, the oral cancer, can be really stopped down in the country. But thank you so much. I would also thank Dr. Sathan sir to chair the session. And I think it has been a great discussion so far. And we now move on to the next session, yet another mind-boggling session, the panel discussion, which we are having for the evening today. So we are going to have a great discussion with numerous specialists from multi-disciplines for actually discussing from their perspective, how can capacity building be done to dethrone the king of all cancers, how the oral oncology connect program for ICanCaRe can be used to transcend the horizons and bring in new changes, new horizons to treat this disease, to handle this notorious king, and how the oral screening tobacco cessation facilities can help to reach out to the community, whether there is a training need, and how these specialists can actually tame the problem which is occurring in the oral cancer in the country. So with this, I take this privilege to invite the moderator for this panel discussion for the evening, Dr. Somesh Chandra sir. He is Director of director and head of surgical oncology from Sterling Hospital and Sterling Specialty Clinics and Cancer Center. He had been the section editor of Hedonic, IJSO, past associate professor of GCRI, executive committee member of ISO, director of KCHRS Gujarat, Baroda. He is also the founder executive member of Gujarat Society of Hedonic Oncology, member of the ethics committee Sterling Hospitals, chairman of Gujarat chapter of Indian Cancer Winners Association with more than extensive 25 years of experience in oncology and cancer surgery. A versatile and dynamic surgeon himself, has had more than 10,000 surgeries performed and nearly 20,000 procedures done in the surgery over this entire decade. I now invite Sir to please introduce the chairperson and the panelists for the day and take the panel discussion ahead.
Thank you, Shruti. And can you, Dr. Himanshu would like to make some comments before we start.
Shruti, can you introduce Dr. Himanshu as well?
Yeah, I'll introduce Sir first. I'll introduce Himanshu. Sir is the director, principal, and professor of head prosthodontic at Seema Dental College and Hospital Rishikesh. Has more than 30 years of extensive academic experience. Fellow of the International College of Dentists, Pierre Fauchard Academy, USA, and International College of Continuing Dental Education, Asia Pacific. He has more than 200 prolific publications to his name. Currently member of advisory review board of 14 journals. Delivered 95 keynote guest lectures and conducted 41 workshops and pre-conferences courses at the international and national conferences. Has visited numerous countries as an ambassador of Indian heritage by Rotary International and also attended various courses. He has been facilitated with numerous awards, which includes the prestigious Appreciation Award for Project Arogya, Free Dental Checkup and Treatment Camps 2018 by then Vice President of India during the 11th International Dental Students and 5th Dental Surgeons Conference in New Delhi. He has also won the Research Peace Award 2019 for International Best Research in Prosthodontics and Oral Implantology. A versatile principal and dynamic person himself, we invite Sir to have a few words before Someshwar takes on the panel discussion ahead.
Thank you, Dr. Shruti, for such a nice introduction. I'm listening to this program since last 1.5 hours, and I'm really delighted to be part of it. And the lecture given by Dr. Kastov, Dr. Anil, and Dr. Puneet was excellent. And we have to do a lot of work in the field of awareness of oral cancer and how to control tobacco. And as everyone told, private organizations and NGOs are working hard. But the main push will come when Government of India will join hands with us. As Dr. Sathan told very rightly, Dental Council of India has make it mandatory to make a tobacco cessation clinic, but it should be functional. It should be fully functional. And our India mostly live in the rural area, so and most of the cancer sufferers are from lower socioeconomic group and living in the rural area. So we have to focus on these areas. So these are my suggestions, and I hope with this panel discussion under the guidance of Dr. Somesh Chandra, we will learn something and we will be able to contribute something to the society for this awareness.
Sir, you're on mute. Somesh, sir, you're on mute.
Thank you, sir, for your comments. And let's get on with the job. We had 3 very important lectures with important takeaways by 3 luminaries who are working to dethrone the cancer and connect the oral oncology program, who are involved in teaching and training and the fight against oral cancer. But as they say, a lone sparrow does not make a spring. And nonetheless, so we'll have some takeaways from all the 3 lectures. The idea of merging the zone of control with the zone of influence from Dr. Kostov's lecture, and how to win after losing on previous occasions from Dr. Pawan's lecture, how to build a program and how to succeed on that. And a lot of takeaways from Dr. Dcruz's program, lecture. 2 important points there where 80% come at advanced stages. And it's largely because of delayed diagnosis. Let me first invite my panelists. Dr. RK Rawal is a professor of Life Sciences, Department of Life Sciences, Gujarat University. I can see him there. Dr. Arun Balaji is the section lead, speech and swallowing therapist, Department of Hedonic Oncology, TMC, Mumbai. Dr. Asif Ahmed, who is a consultant in dental oncology and maxillofacial prosthesis. Dr. Aneri Shah, certified clinical psycho-oncologist, HCG Cancer Center, Ahmedabad. Dr. Madhusha Wagal, I hope I got that pronunciation correct, who is the professor and officer in charge at TMH in occupational therapy, and Mrs. Shruti, who is our host for the entire program and very energetic and very knowledgeable on how to conduct successful program, and who is along with Mr. Rishabh, the backbone of ICanCaRe, I would say. Dr. JK Gupta, who is a dental surgeon, and Dr. Surendra Senapati, who joins us as a radiation oncologist. So welcome all panelists. I additionally invite Dr. Dcruz to be on the panel. We have one missing panelist, Dr. Gauravi Mishra from Preventing Oncology, but I think Dr. Dcruz can more than fill up the void created by her absence. Dr. Dcruz, are you there? He'll join in some time. The 5 main issues were already highlighted by the organizing committee in the brochure. The first was capacity building to dethrone the king of all cancers. And we'll start with that. I feel that oral cancer is just a mask. And the king is really not oral cancer, because a lot of other cancers, say lung, you would see figuring at number 2 or 3 in most of the cancer list incidents. So it's just a mask, and the real king is tobacco usage. And I have some data on tobacco usage. According to the Global Adult Tobacco Survey, GATS, conducted in 2016-17, the overall prevalence of smoking tobacco use was 10.38%, and smokeless tobacco use was 21.38% in India. And that largely, I would say, accounts for the huge difference between the incidence of oral cancer, which is the Indian cancer, the number 1 in males and number 4 or 5 in females, compared to lung and other cancers which are linked with with smoking tobacco. And on that count, I have some questions for our panelists. Just a moment. We've seen that a lot of efforts are being made. UICC on its side is the largest NGO working against cancer. And in India also, we have the National Tobacco Control Program. We have the NCCP running for the past 30 years. I want to ask my panelists in that order, Dr. Aneri and Dr. Wagal to start with. What are the barriers to success of these programs? Is it because we have not defined endpoints? We have left them on an endless path, and we have no definite goals to achieve, that we need to bring down the mortality by so much %, or the detection rates to be going up by so much. So do we lack an endpoint? Is it one of the barriers to success of these programs? Are we working, is it because we are working in isolation rather than in collaboration? Like Dr. Pawan said, someone who comes in with an MI goes away with a stent or a CABG without addressing the basic cause. So we seem to be working in isolation. That's one of the reasons I see. And do our present actions yield results which we see immediately in the next 5 years or 10 years? Or is it really working for the future generation, which is going to be more productive? Australia, we know, has recently embarked on a program not to have any tobacco sale or use by its adolescents and young adults. So we must have some timelines. We must have a horizon on where we are going. And to start the talk, I invite Dr. Aneri and Dr. Rawal in that order, and others can pitch in with their thoughts.
Sir, Dr. Aneri is currently unavailable. She's stuck at the airport. So we'll begin with Madhusha, ma'am.
Yeah, Dr. Madhusha, please.
So actually speaking, I'm an occupational therapist. And I think the right person to comment on or give information on this is from the preventive oncology. But still what I feel is we need to do a lot. Whatever is being done, as you rightly said, doctor, we are doing in isolation. Dr. Pawan Gupta, as I know, I met him in on his one of his visits at TMH Hospital some 8-9 years back, when he had come to our department and visited us. That time I had a word with him, and I understood that he had a lot of plans for tobacco prevention and working on head and neck cancers. So I think we need to do a lot. And as an OT, I think it's more of the rehab perspective when the patient is being treated, or as we can intervene for their prehabilitation when the patient is about to receive the treatment. So prehabilitation is very, very important for this patient to prevent the potential side effects of tobacco and the treatment and the diagnosis. But yes, we need to do a lot. As an OT, if you ask me, we are into education of the students at graduation level. So in the graduation level, if we emphasize on this part, tobacco, and have this as a part of our curriculum, probably this will add to the advantage of the public by and large. And of course, professionals will get more insight into the side effects of tobacco and all.
Madam, do you have in mind any particular occupational groups who need to be targeted? Seeing reports that people who are idle at one place, whether it's a driver or a liftman or a clerk, they are the ones who are more likely to be using smokeless tobacco. For smoking, people generally are now required to go out because of the norms of the offices and public places. But smokeless tobacco, and we know that the duration of exposure to smokeless tobacco is an important factor in causation of cancer. So would you like to target these special occupation because they also belong to the middle and poorer class, which account for the larger number of oral cancer cases?
Yes, definitely. Sir, I had recently visited Silchar, the Kachar Cancer Hospital, and that's the first time I understood that many of the patients have head and neck cancer there, and it is because that is their occupation. Like a lot of tobacco plants or betel nuts I mean, they are growing that. That is the farming that is happening there, and people are into habit of eating betel nuts and tobacco there. So definitely the low socioeconomic strata, as we know, the statistics also suggest the low economic strata is more into this habit of consuming tobacco. So we need to educate them, definitely.
May I ask Dr. Surendra Sinapati? Is he there?
No, sir, he's also not able to join. Dr. JK Gupta and
okay,
Dr. Surendra Sinapati.
Dr. Gupta, An important part of the data which we discovered why oral cancer reigns as the king is that we have late diagnosis. And there's a delay of 6 to 7 months. Is it on part of the physician or is it in part of the patient reporting late?
In place of JK Gupta, can we ask Rakesh Gupta to answer? Dr. Rakesh Gupta, if you are there. Yeah.
Yeah, Dr. Rakesh Gupta, please. So this delay, I wanted Dr. Gupta, if you could highlight, is it primarily on part of the patient in reporting to the doctor, or is it on part of the physician being unable to diagnose or spot cancer early enough?
Good afternoon all, and rather good evening. And I actually joined late, but I can just enlist the reasons why we have not been successful in controlling tobacco. So I think I can do that better. So one thing is that there has not been talked about IEC and awareness activities, and it has been done enough in the last maybe 15-20 years. This has been done enough. So not many patients, you can say, they don't know about the harms of the tobacco. So as earlier said, that the smokeless tobacco is the main culprit in Indian context, because we are talking about the cancers of the head and neck, oral cancers, and SLT is the main culprit in that. So we should now start, actually Government of India and all the states, they should now start implementing the COT Pact and all related act, especially the SLT has been banned under FSSAI, right? So that should be strictly implemented. The ban should be implemented strictly. The spitting should be banned.
Yeah, so, but may I interrupt? See, we know that the control lies with the government to ban. But the area of influence lies outside the government. So we have at least 12 to 15 states which have banned the manufacture and sale of these gutkhas.
Right.
But it goes on unabated.
Yes.
So as a say a social group, a medical social group, a healthy social group, how do we try and influence? Like we have these Lok Rakshak Dal, which are not really the police department, but they are brought up from the society to look after some petty crimes. So is it time that we need to develop these groups, say in medical colleges or in large hospitals, from their own staff, from their students, from their interns?
Right.
Is it important to do that? Because we know that at least opportunistic screening is an essential part of targeting the high risk group, which is going to be the most beneficial.
Yeah, you're right that way. I mean, opportunistic screening, that has to be done regularly and in all the states. But the thing is, I'll come again to that unless the strict implementation of the acts, already available acts, that is done, people, they don't listen to it. People are already aware about the harmful effects, and organizations like Dr. Pawan Gupta's ICanCaRe, they are doing a lot, and they have created a lot of tobacco marshals. So they are doing a good job. But still, I feel that the government has to act. And another thing is the celebrities. Now they are doing surrogate ads. So recently you might have heard about the Akshay Kumar, Amitabh Bachchan, then Jackie Shroff, and Ajay Devgan. They're all celebrities. They are doing ads for these flavored, so-called flavored ilachis. But in fact, they are advertising for pan masala and gutka. As we all know, the gutka may not be available, but the pan masala, when mixed with tobacco, that becomes gutka. And so these celebrities, they have also been requested in recent days, in last 7-10 days, we have been requesting celebrities and also asking MOHFW to make sure that surrogate ads are not done. So I think,
I'd like to point out here that on paper at least, we have an organization which has been working for at least 12 years, the NPCDCS.
Yeah.
I tried to look into the structure of NPCDCS, and it's more of an administrative structure. 2 days back in the Times of India in Ahmedabad, I read a news item that a nephrologist has been put on the panel of NPCDCS. As yet, I have not found a single oncologist on the panel of NPCDCS because cancer, other than dental, oral, and maxillofacial surgeons, is a great concern for all oncologists.
Right.
I see that there are some people from PSM, preventive and social medicine, and oral and maxillofacial specialties in the NPCDCS. But there is nothing from the oncology group to influence the working or to define targets. Like I said, and I would like to ask maybe Dr. Rasif, Dr. Kaustubh is there, if Anil is there, I would like you to pitch it. That is it because we lack definitive targets that in the next 10 years, we need to bring down the mortality by so many percentage points, or we need to screen so many people in each organization. You just need to screen, you just bring out the figures. And the government has launched on a digital health mission. It's very easy to put things on their digital cards, the health cards, which they have. So are we not using technology well enough? We have, Dr. Pawan might remember, tried on a very small scale when we launched the Swasth network and eSwasth for telescreening, but we failed utterly, largely because of lack of funds. But the government is a very big organization, and we have lots of dental associations and oral maxillofacial associations. We have premier institutes like the Tata Memorial, and we have large oncology care corporate setups like HCG. Why can't we pitch in to help the government define how really we can make a difference rather than just doing it on paper? Because we also have a national tobacco control program, which apparently has not delivered. Dr. Kaustubh, would you like to make a comment on that?
Yes, so let me start with something which is very paramount for any MBA studies. Unless you have targets, you will never achieve your goals. This is very important. What Somesh said is a very important factor which decides the progress. Whenever there is any program, there has to be endpoints. The defined endpoints needs to be there whenever you define policies. So once it is not there, then everybody is working on their own agendas and on their own progress. If there is a goal, then only we will be able to define whether we have achieved it or not, whether we have achieved 50%, whether we have achieved 25%, and then the reasons why we could not achieve it, and then correct it. The path can be corrected. So Somesh, that is very important, and probably that is why in my presentation, there was a slide which said that we must have political and opportunistic capacities. So these kind of organizations needs people like the people on this board, on this this conference. If they are there, they will be able to influence the policies and guide them. So when Somesh says that a nephrologist is on the panel, I feel so bad that an oncologist has to be there in the panel, but it's not there.
And the name of the organization is NPCDCS, that's Control for Cancer, Cardiac and Pulmonary Diseases, and these are all preventable diseases. Nephrology and kidney disease are end and secondary disease. Dr. Rakesh, we found in the earlier talks that the age at which people take up tobacco is about 18 years. You are working at the university. Can we, I mean, we have a lot of talk going up on that the IIM has included Bhagavad Gita in its curriculum. And we have so many school textbooks designed by NCERT being modified to suit different important or perceived as important aspects of education. Shouldn't we educate people about this epidemic of tobacco in youngsters, tobacco use? You'll have to unmute.
Yeah. So as Dr. Dcruz rightly said, that the initial age is somewhere around 18. So either when they're leaving the school or when they're entering into college, possibly there should be a part on this tobacco addiction and its ill effects on health as a part of curriculum. So what we have initiated in Gujarat University from the School of Indic Studies, so a healthy lifestyle course is initiated, and that is compulsory for all newcomers. So whenever the student enters into the 5-year integrated courses, one of that will be the Indian traditional lifestyle and the healthy good habits which will make them healthy. So part of that also includes the tobacco and its ill effect. So I think that should be adopted by many other organizations and colleges, because that is the right time to hit. Because once they enter into college, they have got more freedom, because in school it is still restricted to the institution and still under parental influence. But when they enter into college, they get peer influence and they start these habits. Yeah, so we should start with this.
Yeah, so I would suggest that along with the tobacco cessation training program certification course that we have at GU, we write to NCERT as well from ICanCaRe. Dr. Pawan is listening intently, and we try and approach more universities to include this as part of the curriculum as.
So it has to be implemented through UGC. Then every university will adopt that.
Okay.
So that will be the right way to enter into academic institutions.
But it has to begin from schooling level.
Yeah.
I think schooling is very, very important.
Coming
As
back
we talk about sex education and all in the schools, you know, this should also be an important part to be included in schooling.
Yeah, because we are looking at it from the oncologic point of view.
Correct.
But tobacco has a lot of effects. It affects fertility. It affects the look and beauty. And we must remember that at least 10%, more than 10% of Indian females are currently tobacco users. And especially use of smokeless tobacco is pretty high in women as well. So I think we need to work on these points. Moving on, I would like Dr. Asif to comment on this first. The Oral Oncology Connect program, because we saw that oral cancers are not only being treated late, but they are being treated in bits and pieces. So the 30%, the 20 to 50% cure doesn't translate into good quality of life. I call this, we do run something to that effect, and we call it the life-saving, face-saving program. Because these people are, even though saved from death, they are not saved from a social death. So how would you look upon the Oral Oncology Connect program, and what are your views on expanding the horizons and how to involve people?
So in my institution, that is in Tata Medical Center, Kolkata, we see the major chunk of our patients from head and neck oncology and plastic department. So it's the oral cancer patients that are mostly come to us. So as Dr. Anil sir said, regarding every institution are now having that DCI has made it mandatory for oral tobacco cessation program for every institution. I believe DCI should also make an oral oncology subject as mandatory for their curriculum also. So the BDS or the MDS students should know about or learn about oral oncology, and that can again help them because all are not connected to the cancer institutes. So even in the private practices or even in their other institutions where they work, they can implement and do the oral screening much better than without any training of oral oncology.
Yeah, like there is a program in oral pathology. So I think that it's appropriate that we must have a program on oral oncology. In the city of Ahmedabad, it might interest you. We have at least 35 oncology training programs, MCH, DM, MD, and DNB going on. They are largely broad-based. They cover surgical oncology. There is a single program on organic oncology. Few centers have come up with head and neck oncology programs. Do you feel that giving up on general surgical oncology training and focusing more on specialized areas like head and neck oncology would be more fruitful, would serve the community better?
Specialized training, I believe, is all the time better than going with the mass or general screening. So I believe, yes, specific training are more helpful in such screenings camps.
Yeah, so we'll discuss that a little more when we come to the last part, training. Anyone in this panel would like to comment on is it possible to build a model program for oral oncology, oral cancer care, or head and neck oncology, which the program essentially needs to have a multidisciplinary inclusion. So we are not talking about a surgeon, we are not talking about just a radiation oncologist. We must remember that a lot of these patients are nutritionally depleted, which works both ways. It works in causation of cancer and works towards poorer results. Many of them may not be able to complete treatment, they lose weight. We have prosthodontics, we have prosthesis, which is a largely neglected branch. So nutritionists, reconstructive surgeons, prosthodontists, maxillofacial surgeons, and each of these centers which are dealing in oncology should try and have a preventive oncology and a tumor registry program. Would you agree to that? And I mean, is it good that we build a model and then it can be presented for duplication?
Is it for me, sir?
Yes, because you are working at one of the leading cancer centers in India.
Yes, sir. I believe it's a teamwork. First, we should build up a teamwork, and then make a model for it, and that we can get an example. Because it's not a one-man, like only one person can't do everything. So we need a head and neck oncology, the radiation team, the plastic team, the speech and swallow therapist, the prosthodontist, and it should and the dental oncologist also. And then we should build a team, and that makes a proper model for to show as an example, and that can be called an Indian model.
Dr. Balaji, I would like you to add considerably on that thought, because like I said, we make patients oral cripples even though we have saved their lives. And I'd like to highlight the important parts of maxillofacial reconstruction rehabilitation.
Definitely, comprehensive cancer care is a basic requirement for every patient that we treat for cancer management. When we talk about oral cancer, we always talk about post-surgery sequelae and post-surgery morbidities. But we need to understand that baseline functional evaluation is very, very essential. We are not going to see as everyone's rightly said, most of our patients are advanced oral cancer. So when you evaluate baseline, they will be eating only liquid food or soft food consistency. They are not going to eat every food consistencies because of the tumor, such as in the tongue. Patient who comes with a huge tongue lesion, they will be having a lot of difficulties in eating normal food consistency even prior to the surgery. So evaluation should start from the prior surgery and after surgery, and we need to make sure to the patient as well as caregiver about what are all the challenges the patient is going to face post-surgery, and we should not make the patient panic. And we have to tell about our facilities and what kind of rehabilitation that we are going to offer, and continuing of rehabilitation during radiation therapy is one of the key for successful giving quality of life. Because in many centers, as we know that there are 27 regional cancer centers and national comprehensive cancer grid, in there are more than 200 plus cancer hospitals are there, but the rehabilitation specialists are very, very less. That makes it challenging to rehabilitate these patients. So definitely comprehensive cancer care is very, very essential to mitigate the problems.
If I may add to that, when we talk about speech therapists, I have till date not been able to locate one which who can address the special speech disabilities faced by a head and neck cancer patient, because most of them are related to voice therapy rather than speech therapy. And a lot of speech is affected by treatment of oral tongue, which is one of the leading causes of cancer. And we really have no one to address that specific need. The so-called speech therapists who work with otolaryngologists are basically voice therapists and not speech therapists. So do you have at any of the centers in India, are you aware that we have any training programs specifically addressing this need, and how to develop? What would your suggestions be on how to develop this?
I totally understand your point, saying that all speech therapists are not competent in treating this head and neck cancer rehabilitation, because our course curriculum do not focus majorly on this. But we at Tata Memorial Hospital, with collaborating with Dcruz in 2018, we started a fellowship program for master degree speech language therapist. It's a 1-year program. So till now we have completed 3 batches. And our future goal is to start a MSc speech pathology for head and neck oncology rehabilitation. So that is one of the major thing we can develop human resource in this kind of rehabilitation program. And certainly we need to think about a PhD program as well, majorly focusing on oral cancer, laryngeal cancer, hypopharyngeal cancer as well. So training programs very, very essential. As of now, there are very few training programs are available, especially for head and neck oncology rehabilitation. I'm sure in future more and more training programs will be available, and we need to work.
I'll take this opportunity today, and Dr. Pawan, I propose that we make a request to Dr. Balaji's unit at Tata Memorial to have at least observers from various places, so that it is this expertise is, at least some of this expertise can be disseminated more widely throughout the country. So I propose that you think about starting an observership at least, or a short fellowship program over and above your core curriculum.
Sir, I would like to add here.
Yes.
Sir, I would like to add here. Since you are emphasizing on speech, it is definitely required. Most of our patients, and I see how Dr. Balaji is working extended hours is working there. But the patients have many more rehabilitation needs. So as I think Dr. Pavan has already emphasized on trismus, and he has developed something to address the trismus. The patients also have head and neck lymphedema, which is very much ignored and not given much attention to. Then shoulder and neck dysfunction, fatigue, intimacy, sleep problems are there. They are in need of rehabilitation. So you need to actually see the person as a whole, and not just one aspect should be emphasized on. So at TMH, we are working a lot for these patients towards rehab. So if they starting observership, let their observers visit the occupational therapy department as well. So that will benefit the patients at large for many patients in different institutes in our country.
Thank you, Dr. Madhusha, for that excellent offering. And I think Dr. Pavan would have made a note of it, and we should start working on combined observership in occupational therapy and speech therapy at TMH, building a program through ICanCaRe. Moving on to the next point, oral screening, tobacco cessation, and how to reach up to the community. I remember that about 5 years back, during one of our cancer screening camps at one of the public setups, we screened 117 individuals, and I have some data. Just let me check that. So I thought that this data was very important, and I contacted the local leading daily here because the data is like this. We actually measured their mouth opening. In a screening of 117 subjects, approximately 97% males, 52% were users of tobacco and or gutka. Amongst the non-users, the mouth opening was at just as adequate, that's more than 30 millimeters, in 95%. But in the group with 5 years or more of tobacco gutka consumption, only 2.5% had mouth opening, adequate mouth opening, that's more than 30 millimeters. In fact, about 13% of users had less than 1 centimeter of mouth opening. Obviously, these are not data which are published from a very famous source, or these are not data which would astound the normal public. They do not understand the significance of a reduced mouth opening and what it points to, and what is in store for these people in the few years down the line. So oral cancer screening, when we do, if we look at, again, the NPCDCS website, it talks about early warning signs of cancer. These are all telltale signs of either a pre-malignant condition or even an advanced cancer, which are ignored. So building up a effective screening program, at the ground level, they have an ASHA worker working as the last point of contact with the community. And that ASHA worker may or may not himself or herself be a tobacco user. Like Dr. Pavan showed, if practiced properly, there is more than 90% success rate in tobacco cessation, and cancer screening would still be higher. So can we adopt these kinds of models more widely at institutions across the country if we cannot go to the community, because going to the community is largely the purview of the government or large NGOs, which we lack because of lack of staffing, lack of funding, and lack of interest by people who influence the social minds, the media. So do you have any suggestions for going to the media? How do we influence that? Because as clinicians, we are daily engaged in our own clinical work. Dr. Asif, would you like to address that?
Going to the media, yes, we can do it, but how do we do it? We really don't know. I really don't know from my perspective. Because being a clinician and full-time clinician and a postodontist in Tata, going to event, you need an event management or event manager for getting that, doing so. So my personal, I don't have any experience in such.
So Shruti, you know that you are working with Dr. Pawan and now even listening to Dr. Asif, that if you really want to broaden your footprints in the community about screening and tobacco cessation, you have to look beyond clinicians. How do you propose to do that?
Sir, one is definitely having a public figure, someone who has actually quit smoking or tobacco, or maybe at least one public figure whom the people can resonate their thoughts to. When someone can follow Jay Devgan or Akshay or anybody as the role models and take up liking those products, I'm sure with a strong and staunch message. When Akshay Kumar came down with a beautiful ad on traffic control policies, I'm sure that one keen message from a very good public figure can really bring and divert thoughts from the community, from everyone to start thinking about it. And clinicians, of course, also have a role, because it is the ultimate place where the patients come in. And when the patients come in, education, which also Anil sir had said earlier, that education to those patients on these aspects of early screening, diagnosis, and then influencing and taking it ahead, propagating it ahead is also very important. So I think that both clinicians have a role, a public figure also has a role, and also we have a tobacco marshals program. So these tobacco marshals are actually the influencers from Gram Panchayat, from rural areas, from social clubs, from districts, from tier 2, tier 3 cities, who are the key decision makers and also influencers for policy making. These can bring about changes. These can add on to the kind of awareness we want to bring in, the kind of awareness we want to pitch in the community. So they can really create a rage fire and bring that difference. That is how I feel.
How do you motivate these people to do their job?
So the best motivation is something that gaining happiness. I think the one thing which we have found is seeing happiness or saving one's life gives more happiness than actually earning a lot, or maybe doing something where I'm spending a hell lot of amount of money. So this is one factor which we have actually identified from ground, that saving one's life and taking that pride in believing that, yes, I've helped someone and I've done something, I've given back something to the society, is the key motivating factor for these individuals. And that's what we have been doing at ICanCaRe.
We were at some point, we had tried to calculate how much, or rather, many times we have done this exercise, explaining to patients how much they have spent on tobacco, and now they want a free treatment.
Yeah, sir.
Right? And this free treatment, if it is not available, they would get it through a health insurance, and the health insurance companies would ask if there is a history of tobacco use, and if there is a history of tobacco use, they would deny the Mediclaim.
Yeah.
So demotivation that you may be denied an insurance claim for any disease, for any treatment, whether it's CABG or a cardiac stenting, if this thing comes out, can that be a motivation for people to give up tobacco?
Absolutely, so I would definitely agree to it. And we have been trying to push that agenda with the insurance companies and also with the healthcare professionals across the country. Wherever we are meeting, we are trying to create this awareness that there has to be, at least in the form of color code or something has to be given, so that the person clearly declares himself or themselves, or at least the professional declares that this patient is a tobacco user. I mean, it's very sad that the current state of affairs in the country is not, so we're not very practical. We are helping the patient in every possible way to seek those claims by forging and not saying that that person is a tobacco user or a smoker, but we really want to push that. And I am always, we as a team are always looking out for those solutions, how we can really change this mindset. It's a tough job. It's a mammoth task to bring that mindset change. So this is something where I look forward for everyone's idea and brainstorm to see and deliberate how we can bring that change.
Dr. Asif and maybe Dr. Himanshu, do you get such queries from health insurance companies asking and denying them, and how do you deal with that? And is the way we deal with it, most often we deny it, is that the right way forward? Are we helping the cause, or are we defeating the cause?
Well, I would like to add,
Yes,
for
sir.
this early diagnosis or early detection, we should train our young graduates, whether it is dental surgeon or medical people, those who are dealing with the community. The patient is coming to them and they can diagnose it at early stage. So there is no need of extra training for them, because they are being taught all oral pathology, oral medicine, and what are the signs and symptoms of oral cancer. So whenever a patient is visiting some doctor, and if he finds some early signs of cancer, so it is the duty of that treating doctor. He should tell patient and he should refer it to the proper oncologist. This is regarding early diagnosis of the cancer, and this will be a great help. And regarding creating the awareness, sir, I will like to emphasize, because we have to create awareness to the young people as are discussing. So as we are discussing about the celebrities' role, if you see nowadays IPL is going on, and every youngster is watching it. So we can make slides, what are the pre-cancerous lesions or what are the signs of pre-cancers. So they can be publicized through these kind of TV shows or this games during the game. So that will create the awareness, what are the signs. Because everybody is aware for good health. Nobody wants to die, nobody wants to suffer. So if we give them what are the signs and symptoms, what are the early signs, as you said about the mouth opening, we have done some survey of mouth opening. So literally we can tell them if your mouth opening is reduced, if you are having some non-healing ulcer in your mouth, so then you should report to the doctor, dental surgeon or oral surgeon. So this kind of awareness we should create.
Can we have some more opinions in this? Say Dr. Manju Jain and Dr. Rakesh. Yeah, please.
So if we see, usually whenever we are filling a medical form for medical insurance, it is usually first-hand information. So many a times we don't reveal the habit that is there. But if we include that as a criteria, say height, weight, everything, then amount of mouth opening, so in terms of say millimeters, so that is an indirect measurement. Or a point of care device, that is say a drop of saliva can detect the nicotine level, because if that becomes mandatory, and that is useful to the insurance company also, because ultimately it is useful to them for deciding the premium. So those are such point of care device, so that can be handled by even the agent who is visiting the patient or the insurance taker. So these are small criteria which can initiate on a longer run, because then people get aware. Now your mouth opening is also one of the criteria. And for media presence, I would say that in local newspaper, usually there is a health column in majority of cases. So in that, if you voluntarily participate and focus on such writing, or as ICanCaRe has introduced, a medical cartoon, a cartoon character which continues for a week or something, so that because people follow the purtis of the local newspapers. And usually housewives are more onto that. So I think that is one area which can be sensitized, because the housewife is the center of managing the health and everything of that family. So these two.
Yeah, so those are good suggestions, Rakesh. The only thing is that media follows funds. It sniffs at funds, and it would only take up what is funded most of the time. Dr. Manju, you had something to say. Dr. Manju Jain. You'll have to unmute yourself.
So good evening, everybody. I'm from your field. I'm a very different. I'm just a psycho-oncologist, and I've given presentation in American Psycho-Oncology World Congress, Washington, DC, and Psycho-Oncology World Congress, Dublin, as preventive medicine, and in Portugal. So I've been working with Dr. Ajay Mehta, the oncologist in Nagpur since 2009. And with the help of Dental College Dean, I was working on submucous fibrosis. And there was a patient whose mouth opening was just 25 mm. And sir introduced me to the patients and said, you can take up your research. And I just taught them those mantras. And he was a very young boy. And when everything was over, all the doctors were there, and after teaching, the dean asked me how much time it will take, and I said 21 days. Then he came and advised me that it takes 6 months for 1 mm opening to increase. How will you be able to do within 21 days? And I just told that boy, now there's no harm in chanting. You can just keep on chanting, and we will come back after 21 days to this medical college. And then we came back, and when he went to get it measured, his mouth opening had gone up to 30 mm. And they were really surprised. And now his mouth opening has come up to 37 mm. Just by listening to the chant, and he's a Ramesh Sahu. So here's a case study, 2 of them. This just now I paid one case study. This was Gunath Sambalkar, whose voice had totally gone. And my Integrated Healing Forum president, who was principal, Janet National School, he said, out of the 2, even if you get 1 patient healed, I will understand your research. And I was working every day with this patient, and he did not have voice. And he was just chanting with me in his mind, and his wife was also doing that. And after 21 days, he started talking. And I just, when I heard this, I said, you can speak now. And I took him immediately to oncologist, Dr. Ajay Mehta, who's in Nagpur, HGNRI, if you must know, if you know him, he is special breast cancer. He immediately did endoscopy. He showed me even the rise inside, and he gave me immediately endoscopy report, and he said there are no cancerous nodules in his this thing. And he said, you keep this. Didn't even charge me. He said, you're doing such good work. So like
Thank
this,
you. Thank you, Dr. Manju.
And I got a...
Thank you, Dr. Manju. And I'm sure those case reports are very interesting. And maybe someone at Tata Memorial, when they launch an integrated healing program, they would look into it. I would like to move on to the last 2 points which were mentioned to be discussed: fishing or feeding, and the need for training. I think they can be clubbed together. When a dental surgeon or an oral max-fac surgeon is extending support to an oncologist, or an oncologist extends a hand to a dental surgeon or oral max-fac surgeon, how is it looked upon? Is it looked upon as fishing, or is it looked upon as actually hand-holding? So is it a doctor-centric activity, or is it a patient-centric activity? I have come to believe that at the best centers, we have a science-centric treatment paradigm. At many other places, we have been accused of having a doctor-centric treatment paradigm. But I'm sorry to say that I have come to realize that we hardly ever have a patient-centric treatment paradigm. Because if we do that, these questions would not arise at all. And from that, I would move on to asking about how do you develop a training program. Dr. Anil said that specialty programs are very important. They have been shown that they yield results. So treating is not enough. You have to treat them right. There was an entire edition of EGSO, European Journal of Surgical Oncology, which addressed what was more important. Was it numbers or was it training? Obviously, both are important. You need to have adequate numbers to get adequately trained, but the quality of training is definitely more important. So when you extend a hand, is it to offer your services or is it to gain something from the other? So is it right for a dental surgeon to extend into the field of oncologic resections without proper training, without understanding the science of oncology? We as oncologists understand that oral cancers are far more sinister than, say, a breast cancer by and large, or a colorectal cancer. They are very fast growing cancers, and they would punish you with a recurrence and death very soon, not 5 years, 10 years down the line. So I would start off with Dr. Asif. I would come to maybe if Anil is there, I'll come to Dr. Anil and Dr. Costa, who are all running training programs. And how do you look upon this association with different specialties? Is it fishing? Is it feeding? And how do you do that? Because it's said that if you give a patient a fish, you feed them for a day, but you teach them fishing, you feed them for a lifetime. Dr. Asif, to start with you.
Thank you, sir. So in this, I would like to say that we should always be trained before we touch the patient, not only doing a surgery, even by giving a medicine also. So you should be trained first, and when you're trained, so in Tata Medical, what we do is we offer trainings like training programs like Prayash, TMC Eco, which is done on Saturdays, and it's mainly targeted to the BDS students or the Ayush doctors, where we teach them regarding the screening part, all oral screening, cervical screening, gynecological screening, all of the screenings are taught over there. Then we have observerships, as Mr. Balaji has already informed regarding that. Observerships are very much important. They come to know what is oncology, how do we deal with oncology patients, what are the different aspects of oncology. So training is definitely is never a doctor centric, but yes, it helps the patient as a whole, not only in the institutes but also wherever they go and practice their specialties.
So do they come to you trying to learn a resection so that they can do it on their own, or they try to learn that when a resection is done, before, during, and after that, what is their role as a dentist? So that message is very important.
Sorry. So first to diagnose it. What is it? What we are dealing with? Is it a cancer? And if it's a cancer, how do we approach the patient? First, the approach is important. Once that is dealt with, then yes, the resection part. But being my prosthetist for myself, we deal with the prosthesis part, the silicons, the extraoral or the implants in fibula or in any other in a normal alveolar bone also. So this is how we teach them that where you have to put implants, where we can't go in for implants, the different stages of ORN or Morange, different things that can happen if we do extraction in the bisphosphonates, what are we going to make the patient suffer from? So these are the trainings that are required in what you teach them.
Right. Dr. Costa, we would like to add to that. You'll have to unmute yourself.
Yeah, Somesh, this is a very important point, and I have some thoughts. Before about 5 or 6 years, we could find that there are lots of maxillofacial surgeons operating on head and neck cancer patients, and then we had a lot of adverse outcomes. Now we realized that there's no point in telling anybody not to do something. The right thing is to tell them how to do it. That is the most important thing a trainer or a leader should understand. So the first point was to start training properly the oral oncology. Now, what happens is that in the many of the dental colleges where this is being taught, the surgical oncology angle is lacking. And that is the reason why there are lots of issues with this training. So we at Foundation for Head and Neck Oncology, when I was president, we took a challenge and we devised a curriculum on oral oncology for maxillofacial surgeons. And this fellowship is 2-year fellowship, institutional fellowship. We started all across India, and now there are 32 institutes. These institutes are cancer centers, and they give training to maxillofacial surgeons to become oral oncology certified by FHNO. So this kind of a precise institutional training is required to then start offering these kind of surgical or treatment modalities to the cancer patients across society. So the maxillofacial surgeons should understand that they need training. The surgical oncologist must understand that we are not enough. If you have gone through my lecture, you must have understood that what kind of an oral cancer epidemic is going to come, and there are not enough specialists to treat these patients properly. So all of us should focus on training more and more people into the right way to treat this disease. And that is what, and this fellowship, just for your information, is there is an entrance exam and there is an exit exam. And once you pass that exit exam, then only you are given the certificate. So it's a stringent kind of a curriculum. And if these kind of programs are done more and more at more and more centers, probably we will have properly trained maxillofacial surgeons working into community, giving good results. Except this, if they are not well trained, I think at college level, they must understand that their role is to detect early. Their role is to biopsy, to diagnose early. Their role is to rehabilitate them properly post-treatment. Their role is to support oral surgeon, oral surgical oncologist peri-operatively for prosthodontist and other dental rehabilitation issues, as well as mandibular reconstruction, where their expertise of plating and screwing and making mandible, the reconstructive aspects better. These are all the issues which they are supposed to add into as an expert. But if they want to do a resection, then I think these kind of proper training is a must. Otherwise, it will be not fruitful for the society.
Thank you for those very incisive comments, because before you dissect, you need to understand the disease, you need to understand what kind of radiology to do, and all those things. So there are various elements of a training program which a good center would adhere to. Before winding up, and this could be the last comments, I would invite from Dr. Himanshu and Dr. Rakesh Gupta, if he's there, that in your busy dental practices, wherein oral cancer is a small number, would form a small number of patients that you see, how easy is it to miss one? And how do you devise a plan not to miss those infrequent encounters with oral cancers? And what would your suggestions be to all the dental practitioners on how to set up a opportunistic screening program for oral cancer?
As I've told you earlier, I will like to say because I totally agree with Dr. Kostov. The role of dental surgeon is not in curing or resection of the cancer, because that is a specialized job and we need team of the people. In most of the hospitals, good hospitals, we have tumor board. The role of dental surgeons may be there and is there to diagnose. As we are discussing, early diagnosis is very good. We can prevent the loss of structure if we have this diagnosed it at early stage. And in this role of dental surgeon, whether it is a conservative dentist, orthodontist, prosthodontist, he is seeing oral cavity as a whole. And all dental students are being taught as per DCI curriculum and they know early signs of oral cancer. There is no need to further training for early sign of oral cancer. So their role is very crucial. They can identify the oral cancer and without any agitation, they should refer it to the concerned specialist. That is the first very important role of dental surgeon and they should play very important role in this. Another thing is screening. As we are discussing, we are organizing a lot of dental awareness camp. Last day only I finished a camp where we have examined 400 patients examination. So when we are doing such camps and we find any such lesion, reduced mouth opening or tongue cancer, oral cancer, we can, as a dental surgeon, we can locate it. So then we should definitely send them to higher center for the proper examination. And another role, as Dr. Asik is telling again and again, role of prosthodontist. Because once a surgeon, oncosurgeon has operated, loss of structure is there. And everything can't be do again by the reconstructive surgery. The role of reconstructive surgery is there. But whatever reconstructive surgeon can't do, that as a prosthodontist, I can tell you, as a prosthodontist, the role of rehabilitation by a device is very important. As we are talking about speech, you know, speech is the articulated with the palate, tongue, and teeth. And once after surgery, this has been lost. The role of prosthesis is there. We can have implant-supported prosthesis. We can have obturators. We can make a fast palate which can produce the sound. So in all these things, the role of prosthodontist is very crucial. And all MDs in prosthodontics are being taught this. And they are doing this kind of prosthodontic rehabilitation. So these are the two crucial roles of all dental surgeons. And they are already in the curriculum of BDS and MDS. But as Dr. Kasto very rightly said, if anybody, any maxillofacial surgeon want to do some kind of oncosurgery, he must be trained. So this is my suggestion, and we are competent enough to do this for early detection of cancer and rehabilitation part.
Thank you, sir. Dr. Rakesh Gupta, would you like to add to that?
Are you asking me?
Yes, sir.
Okay. Actually, I'm not a dental surgeon. I'm an ophthalmologist, but into public health for long, especially in tobacco control. So since dental surgeons, they are the first point of contact. So each dental surgeon, they must ask about the tobacco chewing habit, especially smoking also, but the tobacco chewing, I think, more important as far as the India is concerned. And we in CTCS, because I have recently done CTCS course from ICanCaRe, so they teach very elaborately how to detect precancerous lesion and the cancerous lesions. So I think that should be part of the curriculum of the BDS and MDS as well. So that will definitely help. And dental surgeons, they definitely have a role in detection of the oral cancers and the cessation also.
Thank you, sir. If there are any more suggestions coming in, how not to miss a red flag, how to send it to a specialist on time, they're welcome. And after that, we'll close this session. Dr. Pawan, you have, I think Dr. Dcruz is there for any final comments, or has he listened to any of these?
Sir, in Dublin Trinity College, they have art as a therapy, music as a therapy. Doctors from London come and give presentation how people with this thing, they just play mouth organ and there is relief in their pain. And They have all the cancer patients, they make paintings and people buy also, and they make potteries. So art as a therapy and music as a therapy. Even in Stanford, I have seen that all
Yes,
the
madam. If I may interrupt, I'm sorry to do that because of lack of time. There are about 50 plus, about 52 designated cancer centers in the US, and 48 of them have something to do with integrative therapy. Music therapy was introduced at Memorial about 10 years back. We introduced music therapy for our patients 5 years back with specialists. Somehow it doesn't have that kind of acceptance in our patients, and I think that aspect needs to be developed in a more scientific way. But your suggestions are very appropriate, that we must address the patient's need integrative in an integrative and holistic way. That point is well taken. The point which came out towards the last of this panel was that we are addressing the needs of a cancer survivor inadequately at present. And because we are not adequately trained to do that, the people who are primarily involved in curative treatment, these aspects of survivorship are beyond their purview, and those who address those are working in a multidisciplinary fashion at only very select centers. So we need to broaden this, the footprints of all the supporting specialities. And with that, I would thank everyone. Yes, Dr. Costa, you had something to say.
Just a small comment that, as we saw, prevention, early detection, and treatment, the highest impact will be from prevention and early detection. But both are they need funding, they need cost. There are lots of cost implications. And that's why high-risk screening is the key word. And my message would be to do that rather than screening general public, because we had a very small study, 122 police workers who were taking tobacco. So their doctor screened them whether they are taking tobacco or not, and whoever were taking tobacco were screened. And we could find out 40% pre-malignant lesions, and we could find out 3 early cancers in these 122 people. So what I feel is that when we say that about 60% of adults are using tobacco, and out of this 60, if the detection is done, the rate of detecting malignancy, early malignancy, and pre-malignant lesions will be many-fold more than what our general data, which everyone has presented, suggests.
Thank you, Dr. Costa, for those comments. And I would say that we can wind up with the final thought that oral cancer, which Dr. Pawan calls the king of oral cancer, of all cancers in India, is indeed a public health problem. So much so that it mandates, and it is a preventable problem. And so it needs screening, a proper screening program. And there are various people, the people who are the points of first contact, primarily oral and dental surgeons, who should take the onus of early detection and screening. The main impact could be from screening high-risk individuals. That's a proven fact. And it's a simple way, just an oral examination is a very effective way. It's been proven that it can reduce mortality from oral cancer just by a proper oral examination. We need to train people in this. And for prevention, we need to train people in tobacco cessation programs, practiced in a scientific way. And for that, we need to reach out to the community. And we need to erect heroes who are successful at this and who can be our brand ambassadors. Thank you, Pawan, Shruti, for giving all of us so much time. Anil, we were missing you throughout the discussion. If you have any, mostly we repeated what you have been saying all these years. So,
Sumesh, I was following the discussions. I deliberately turned off my mic because I said I would like to hear other people's viewpoints. I had shared my views in my talk and I had a big time. They were generous to give me 30 minutes to speak. So I just thought in all fairness, I would like the other panelists to participate. But I totally agree. Wonderful panel. Congratulations to the organizers, to you on your excellent moderation, and to all the panelists for some great insightful thoughts. We have to do something. I leave with one thought. You see, we have about 700 districts in the country. We have 300 dental colleges. If each dental college, when they apply to the Dental Council of India, are given to adopt 2 districts in their vicinity and run screening camps, you don't even need all this high-risk screening and things like that. We need innovative thinking in our country to prevent it. And put the government cannot do everything because we don't have resources. But it's up to healthcare leaders such as Kostub, yourself, who influence a lot of policy in this country, to give government good suggestions, and I'm sure they will accept them. So thanks once again, and I don't want to be very long in my comments. Great panel, and hopefully we'll make a dent in the years to come.
Thank you, sir. Shruti, over to you.
Thank you so much, sir. I think that's all for the day. We come to the end of the wonderful 4-day program. We had a terrific discussion throughout the day, a very great discussion in terms of hearing all the visionaries, the solvers who have been there with us to share all kinds of information for the day. And now with this, I would like to invite Pawan sir, because there was a short video which he wanted to share, followed by Suman ma'am, who can share her comments quickly within a minute, and then we move towards the validatory session.
Thank you. And I think the most important is involving everyone. See, when we talk about the cost can be dissipated when we involve and train the dental surgeons and when they become inclusive of our program. So without commenting further on that, I'll just share the screen and present a video which we have made on the RiskBased instrument. And Shruti, I'm not able to share. Yes, now I'm able to share. Okay. So this is a RiskBased instrument that we made, and a lot of people have been asking me privately about this. So I just thought that I will.
So you need to share sound.
Thank you for allowing me to showcase this video. And just the good part is that this is now being enrolled or being put in the GEMS and HLL. So it will be available across all the government organizations if they want to have it. and we have been putting this, a lot of hospitals have been asking for this. So and we are shortly starting we are looking for a trial on this with the various groups of various hospitals. So we'll look forward for the doctors who would love to be part of the trial program. So thank you so much. And it has been a wonderful 4 weeks program. So we come to the valedictory and we have all the dignitaries here. So I think, Kaustubhai, please do wait for some few more minutes. And we have the quiz results also coming up. Over to you, Shruti, to take it further to the valedictory function. Thank you.
Yeah, but I'll just quickly invite Suman, ma'am. Ma'am, please 1 minute for you to share your thoughts and we take ahead to the valedictory.
Thank you, Shruti.
Oh, yeah, Suman, ma'am. Yes.
Yeah, thank you, sir, for having me here right now. I am heading Department of Surgical Oncology at ESIC, Basai Darapur. Now, ESI is a very structured hospital which caters only to labor class population below 20,000 gross income. So it's basically low income group. And each hospital is added to a set of dispensaries. Despite that, when we did our data analysis of all the oral cancers, we had 100% tobacco use. And that made me go thinking, and I joined the CTCS program started by Sir last month. And now what we are doing is we are analyzing our data and putting across the comments and suggestions to the Ministry of Labor so that ESI doctors can be enrolled in CTCS programs, and at least each dispensary could have 1 or 2 CTCS specialists, so that this menace, like all our patients are stage T3, oral cancers T3 above, most requiring composite resections. And all of the patients are below 50 years of age. That means it's a prime workforce of the country. So that's why now we are putting a suggestion, and I will definitely share with Sir what happens to that. And that's it. That's what I wanted to share, actually.
Thank you so much, ma'am, for those wonderful thoughts. I mean, hats off to that initiative that you're taking ahead so that more such people who need help can really get in help. So with this, now I think we come to the concluding sessions. It has been a terrific 4 days program. So much of information, so much of knowledge. I mean, we are just flooded with compliments across the social media for this program. It is we have received this compliment that this was better than last year, because last year was mostly technical. So the audience were technical. This time, because it was multidisciplinary, so we have a lot of people understanding a lot of aspects of how they can work together with the specialized and the experts in head and neck oncology to really make a difference in the community. With this now, I take this pleasure to thank our partnering organizations once again, because they are the ones who have been tirelessly working, our organizing committee who has been tirelessly working for the past 2 months to really make this a success. A quick event report of what has been the success story so far. So we had 990 registrations this month for this program, with more than 1,300 viewership and more than 30 plus disciplines participating in this program. The lead organizers for the program were ICanCaRe, Foundation for Head and Neck Oncology, Sterling Cancer Hospital, Specialty Clinics and Cancer Center, and Gujarat University. We also had 16 faculty, 20 chairperson, and 36 panelists, the prolific and extraordinary experts from across the country participating in this event. 4 very extraordinary and versatile moderators, the key opinion leaders, Dr. Narayan Subramaniam, Dr. Abhishek Vaidya, Dr. Arun Patel, and Dr. Somesh Chandra, who took us and delved us into thought-provoking ideas and made our brains thinking that what we can do. The sky is the limit, and there's a hell lot of opportunities lying out there with every one of us that we can really make a difference and add things to the society. As for the quiz, this was very terrific because we had 123 participants who were participating in this competition, of which 20 winners will be announced for this evening. We had 3 quiz masters, Dr. Vasanti Jirge, Dr. Mitali Dandekar, Dr. Harsh Dandekar, under the guidance and leadership of our quiz leaders, Dr. Dushyant Mandlik and Dr. Rashmi Shukla ma'am, who really made this quiz happen. The quiz prizes are again terrific because the first 3 winners are going to get scholarship, a very good scholarship for the Certified Tobacco Cessation Specialist Program. All the winners are going to get the prize-winning certificate along with gift hampers from ICanCaRe, which includes a special coupon code to buy products from ICanCaRe at 25%. The top 3 winners are going to get gift hampers from Maji Food. And of course, let's see if there are more excitements which are awaiting us. So a quick glimpse about the CTCS program. This is a very effective tobacco cessation program, which has been researched and deliberated and structured with Gujarat University to help people quit tobacco with ease, and the success rate stands at 92%. It is data-driven, evidence-based, and is purely based on the lifestyle of an individual. We help them quit successfully by adopting practices in their routine means without undergoing much challenges. And so now here I invite our quiz leader, Dr. Rashmi ma'am. Please announce the winners, the first 20 winners. We'll first announce the first 3 winners who are the champions for the quiz competition. And next, we're going to have the 17 consolation prize winners for the quiz. So over to Rashmi ma'am.
Thank you, Shruti. Thank you so much. So we are now going to announce our first...
Rashmi, your voice is not clear. If you can.
Sir, it's clear now? Hello?
Better, but still not very clear.
Just a minute, sir. I think now better, sir?
Yeah.
Okay, so we are now going to announce our first, second, and third winner. So next slide, Shruti.
Ma'am, the name is displayed on the slide, ma'am. We have displayed the name for the third winner.
Just a minute.
A big round of applause for the third winner, Dr. Neelam Mahirwan. I'll request all participants give a big round of applause to the winner for the third place.
Yeah, so congratulations, Dr. Neelam Mahirwan. You have won the third prize. Then the second prize goes to Dr. Garima Upreti. So congratulations.
And the first prize goes to
Dr. Lokesh Kumar S. So a big hearty congratulations to you for winning this prize. And now I take this privilege to announce the winners, the consolation prize winners. So we have Dr. Kirti K. Nair, Dr. Kush Shah, Dr. Shahid Rasool, Dr. Ranjita Mehta, Dr. Kanato T, Dr. Arpan Chaudhary, Dr. Karpa Gavali, Dr. Varsha BK, Dr. Anu Ramachandram, Dr. Vishali Malik, Dr. Shanchit Bajpai, Dr. Sarvesh Arzankar, Dr. Dimla Denny C, Dr. Divya Kukreja, Dr. Jyotika Preeti, Dr. Aruna DS, and Dr. Saraswati Welling. So a big round of applause from our audience to all these winners who have done a great job and they've won these prizes. So these are the consolation prizes for the 17 winners. They're going to get a 20% scholarship for the CTCS program. The first winner is going to get a 50% scholarship. The second winner gets a 40% scholarship, and the third winner gets the 30% scholarship for winning this quiz competition. So now I'll invite Pawan sir to break the silence, to break the excitement, and also tell us what is special about this encouragement prize.
Yes, so we had actually 123 participants for the quiz, and of which we got 44 participants who were eligible for the prize winning. 20, as we had announced earlier, 20 will get the prizes as the scholarship as well as gift hampers and 25% gift coupons. But we at the ICanCaRe, we thought that the other who have also been eligible for this prize or who have been eligible for the contest by being attending all the 3 quizzes. So we have specially given them that we will give them an encouragement prize, and we will also offer them a scholarship of 15% on the CTCS course. So this was a special prize that we thought that we will provide them. So all those the winners, if I can read them out, Dr. Sonam Sharma, Dr. Sharthak R. Trivedi, Dr. Richa Singh, Dr. Urvashi Goyal, Rashmi Verma, Dr. Anshul Jain, Shruti Jain, Ankita Malik, Dr. Monish Muchal, Satabdi Kumari, Nancy Verma, Dr. Farheen, Bhavna Rani, Dr. Richa Sharma, Shipra Chandrakant Deshpande, Dr. Monika Kumari, Dr. Ashtha Doshi, Dr. Arjun D. Sinde, Sarika Jain, Amita, Dr. Monika, Harish Venkatraman, Chandresh Pragya Verma, and Priyanka Singh. So they all also get special encouragement prize for being part of the whole program all the 3 days and all the 4 days rather. and we welcome you to become a CTCS, and we are specially offering you a 15% discount. Along with that, a gift coupon of 25% on as a gift coupon, right? So thank you so much for being part of it, and congratulations to all of you.
Well, thank you so much, sir. And now we move ahead to have the formal addresses from the resource person. So I would like to invite Dr. Prathamesh as President, the current president of Foundation for Head and Neck Oncology. Sir is a professor of Head and Neck Surgical Oncology at Tata Memorial Center, and a versatile surgeon with several interests in laryngal and skull-based surgery with focus on laser and minimal access. So now I invite sir to please give his address.
Thank you, Shruti, for that introduction. And we have seen over the past 4 weeks how Pawan Gupta and his team have endeavored to do capacity building. And we have heard from today's discussion how it is very vital to have linkages right from the primary dental care surgeon to the treatment physicians. And it is not just the treatment, it is also the, I think there is some disturbance.
Sir, I'll just unmute. Sorry. Yeah. Sorry, sir. Please continue.
So we need to develop these linkages right from the periphery to the tertiary cancer centers. And along the way, it is vital to understand that we need to create this workforce that will detect early oral cancers in the patients who are at high risk. So today's discussion highlighted that amply, and we need to focus on prevention and early detection in order to challenge and treat these oral cancers, which is the king of oral cancers as decreed by Pawan. Thank you very much for association of FHNO, and we together will definitely treat this scourge of cancer in the country. Thank you.
Thank you so much, sir. I think that was an extraordinary remark which you mentioned, that together we can really make a difference. And now I would invite Dr. RK Rawal, who is professor at Life Sciences Department of Life Sciences from Gujarat University, to kindly address the audience with his wise words.
Namaskar. So on behalf of Gujarat University, which is the first of its kind in India to offer such courses on tobacco cessation, and as a part of the co-organizing committee also, I wish to congratulate all the partner organization and the whole team of ICanCaRe for successfully organizing this event. And there are a lot of take-home messages from this 4 days event. And I wish that the several criteria that have been discussed today can be implemented at the university level, and I would convey that to our academic council also, that how forcefully we can implement that and make it mandatory, so that our young population get benefited and they are restricted from this addictive behavior, and we help the society at large by this. And thank you all for participation, and I wish good luck to all the stakeholders. Thank you.
Thank you so much, and I'm sure indeed all the teams and respective organizations have derived a lot of inspiration to actually carry forth those activities at the institution level. With this, now I invite our patron, our dear Dr. Somesh sir, for his audience address. We have heard him terrifically at the panel discussion, and now I would like to have his closing remarks for the day. Somesh sir, you need to unmute yourself, sir.
I would start off and end with thanking you and Rishabh for excellent work, and Pawan for his incessant and immense efforts that he has been putting it throughout the years. I mean, we have been associated for more than 2 decades now. We started something called Swasth Network, which was largely about screening for NCDs. And we had a page, a section called eSwasth, where it was all about telescreening. And we have not given up on that thought yet, though we didn't make much headway even after say 3-4 years of trying to conduct such programs. But I think Pawan has shown how to succeed after initial failures, and that's a great takeaway. Coming to this oral E-Conclave program, this is our second year, and this I feel is at least as successful, if not more, than the previous one. We had maybe larger numbers because of people being at home because of COVID, but this year the numbers may be less, but I think the content was even better, and Pawan has already planned for 2023, and the theme is that we have to involve everyone, and everyone must do it, but everyone must do it in the proper way. So we'll continue to work on that for the next 8 to 10 months and see how we can shape up the next year program. And thank you, everyone, Prathamesh, Dr. Alok, Anil, for supporting in such a big way. Special thanks to Prathamesh for making the program so scientifically interesting. The first 3 days of scientific program was largely done with Dr. Prathamesh's help. So thank you, everyone, and best wishes.
Thank you so much, sir, and thank you so much for blessing us as well, me and Rishabh both, to take this ahead, and for the beautiful and the kind words which you have given us now. With this, now I invite Dr. Alok, sir, Dr. Alok Thakkar, Governing Council Member from Foundation for Head and Neck Oncology, also Head of Department at ANT AIMS, Consultant Surgeon and Professor himself, and a very dynamic person himself. So over to you, sir, for your address.
Thank you, Shruti. Many congratulations to you, and of course to everybody at ICanCaRe, particularly Dr. Pawan Gupta and Dr. Somesh Chandra, and of course the entire team. I find that this forum is a little bit different from the so many other CMAs that have been happening, in that we are not just talking about it, but also actually putting birds into action, which is where the difference really is. That there is more focus on prevention. There is more focus that is actually happening on the ground by this forum. And of course, the testimony to your popularity comes from the number of people who are logging in to hear what this forum is going out, both in terms of prevention, rehab, and also the usual things that we talk about, which is about treatment. So many congratulations to you. Wish you more success.
Thank you so much, sir. I'm sure with your blessings and with everyone's support, we're really going to make that difference. And the next year program is again going to be as terrific and prolific as it has been in the last 2 years. I'm sure the next year program is going to have much more better content and quality than it is this year, because this year we gave insights and we provoked thoughts among multidisciplinary specializations to think and to really collaborate together rather than working in silos. There was one common message from everyone: let's work together, not in silos. So I'm sure with this message, all the people who are here with us are going to really make out a difference and connect with you at the given location, at the given regional level, so that everybody can really contribute and make a difference. So with this, we come to the end of the program. So that's all for the evening. That's all for the day. And I would like to formally propose the word of thanks on behalf of the organizing committee. So ladies and gentlemen, thank you so much that you have been a part of this program. And I, on behalf of ICanCaRe, FHNO, Sterling Cancer Hospital and Gujarat University, take this privilege to propose the word of thanks for the evening. Dear audience, the wheels of hard work had been churned over weeks to bring out the successful program, and there has been tireless effort from all the spokespersons and resource persons involved to make this really successful and to deliver quality which is there, which you see today. We all express our heartfelt gratitude to our chief patron, Dr. Anil Dcruz, who honored this event with his inspirational thoughts and very lucid yet extraordinarily differential tactics for managing oral cancer in the country. A big thank you to Kaustubh sir and Pawan sir for their visionary approach and showcasing us the way for mitigating oral cancer for the evening. Big thank you to Somesh sir for giving us insights through the medium of panel discussion of how actually a capacity building can be done in the country to tackle this problem, this menace of oral cancer. Big thank you to Prathamesh sir, Dushyant sir, Arun sir, Alok sir, Rashmi ma'am, Vasanti ma'am, Harsh sir, Dr. Rakesh sir, Rohit sir, Reena ma'am, who has been tirelessly working from across the entire gamut of 5 weeks to 8 weeks to ensure that yes, all the details are fulfilled, everything is managed and everything is there in place. I would like to also extend heartfelt gratitude to Dr. Rajat Saha, Dr. Keshav Nathani, Dr. Geetika Sharma and Dr. Rashi Agrawal for being the backbone and support for this organization and to help conduct and organize these programs. I would like to thank Rishabh Agrawal, who has been technically managing all these events and handling the all technical details of the program, all websites and everything. He's a tech guy for ICanCaRe and he has been doing it terrifically. I would like to thank all our chairpersons, Dr. Manish Munjal, Dr. M.K. Sunil, Dr. Pravesh Mehra, Dr. Samit Chopra, Dr. Shalu Rai, Dr. Usha Agrawal, Dr. Gopa Kumar, Dr. Dhirendra Shivastav, Dr. Ranjit Kumar, Dr. S.K. Kataria, Dr. Surendra Dabas, Dr. A.K. Diwan, Dr. Anushya Sharma, Dr. Manoj Johar, Dr. Ashok Shenoy, Dr. Srinivasan, Dr. K.K. Handa, Dr. Swatantra Agrawal, and Dr. Himanshu Meron for making this event a graceful one with the presence and with the terrific knowledge and extraordinary knowledge. I would like to extend heartfelt thank you once again to all our faculty, including Dr. Madhusha Magal, Dr. Aneri Shah, Dr. Asif Ahmed, Dr. Arun Balaji, Dr. Rakesh Rawal, Dr. Dr. Aparna Shukla, Dr. Vipin Parthwal, Dr. Bidhu K. Mohanty, Dr. Ratan Shetty, Dr. Arjun Singh, Dr. Mudit Agrawal, Dr. Richa Vesh, Dr. Mani Parmar, Dr. Jyotna Sheth, Dr. Shiva Manjunath, Dr. Vikas Goswami, Dr. Jyotika Jain, Dr. Deepak Balasubramaniam, Dr. Ashutosh Vatsyan, Dr. Kapila, Dr. Rahul, Dr. Kinjal, Dr. Dinesh, Dr. Srinivas, Dr. Ashish Kumar, Dr. Sandeep Oja, Dr. Niti Kapre, Dr. Anurag Yadav, and Dr. Amit Jano, Dr. Diva, Dr. Prashant, Dr. Aditya Joshipura, Dr. Neha, Dr. Rajiv Desai, Dr. Swagnik, Dr. Darshana, Dr. Manoj Tayal, Dr. Ankur Mittal, and Dr. Vishal Dang, Dr. Deepal Shah, Dr. Rajashri Banerjee, and Dr. Abhishek Mahajan for terrifically sharing their knowledge and making this event a great happening event for all the 4 days. With this, I would also like to extend heartfelt warmth and gratitude to all our audience who has been there with us for all the 4 Sundays and enjoying this program, sharing their thoughts and feedbacks, flooding us with comments. Please do stay with us connected on the Facebook page. The link is already there in the chat box. Please do visit the websites of FHNO, Sterling Cancer Hospital and Gujarat University to know more about the programs which are already running in the country. Visit the ICanCaRe Academy page website to know the programs which we are running at ICanCaRe to skill up for tobacco cessation and other programs coming up soon. With this, I now open the forum for open discussion. We can quickly have compliments and comments from the audience for 5 minutes and then we close out. Thank you so much, everyone. Have a wonderful time. Have a great time ahead. And I'm sure together we can really make a successful event. So it's an open forum now, open to everyone.
So just before we end, I just want to tell this thing on 2023, the theme that I had kept, and I think everyone agrees to that, do it, but do it right. That was the theme that we have proposed. And I hope everyone, all the chairs and the patrons will agree to that. So if they agree, then we will go ahead with that. So do it, but do it right. Thank you so much. And we have Dr. Anil if he wants to say something. And it's open for everyone.
Thanks. Pawan, let me then just say, since no one's speaking, congratulations. I think everybody has praised you and Shruti, but I'm really amazed as the enthusiasm that Shruti has. I mean, I've never seen a vote of thanks where everybody on the program is thanked. It's the first for me. And I know, and I sincerely believe each time that Pawan gets a little tired and flags off, you are there to push him on. So congratulations. She's nodding. So what I said is absolutely correct. But I think I just continue with what Alok said, that here is a group that is not only talking, but doing action as well. And I leave you all with one message. It's nice that we have this group. It's nice that we have this forum, and it's lovely that we are planning for 2023. But let's not lose focus. Let's not lose steam between 2022 and 2023. So maybe when you come back again in 2023, the first part of your program should be open to all these thought leaders to tell us what they did to tame the king or kill the brute between this program and the next. So that should be the opening session next time. In our own little silos, if we can even influence people who work with us at our hospitals, at home, within our family, to kick the habit, if we can do a little bit of early detection, like Kostub said, going to some police headquarters, just each of us do one little, I'm sure this little stone that you've thrown into pond with the ripples will go out, and slowly we will make a dent in the years to come. So thanks once again. I won't be president in 2023, but I urge you all to please keep me on the program as well. I'd love to be there, at least to learn. Thank you very much for having me there. Thank you.
Thank you so much, sir. And you are always there as the chief patron, and you are the guide behind all this program. So whether it is UICC president or not, that doesn't matter. What matters is you are there with us. That is the most important. And so I want to propose something. Sir.
It's the love for Anil Dcruz and not the love for UICC that everyone runs after you.
Yes, absolutely. So just what Dr. Anil said, I have a special proposal that what we have started as Oral Oncology Connect program, if we can have on the panel all the senior doctors, we can extend this program across India. So this is something that I propose with the FHNO and all the senior doctors, that Oral Oncology Connect program, where we have got multiple, actually Prathamesh and Dr. Alok were not there when I presented the Oral Oncology Connect program. We have got 10 pointers on that. So I will send it separately to you, sir. And so that if you can go through it, and we have all the opinion leaders, all the leaders across India joining hands, so that we can collaborate with the dental professionals and dental people, so that it will really make a difference. Yeah, this is the one. So thank you, Shruti. So Dr. Alok, and just to put it here, kahan gaya?
Sir, 1 minute, I lost it. I put it on presentation mode, I lost it.
Yeah, this is the one. So this was the sub program that I had proposed, that we have started Oral Oncology Connect program. One is that we have CME programs with different idea groups in various cities of UP. So if we have Dr. Shomesh as the leader at Gujarat, so they can have a team there working with the smaller idea groups at various cities and talking to them about how to get involved in oral care and tobacco cessation. Then OSC RTM roundtable meets, which we developed with inclusive of oral care surgeons and oncologists together. Then what I propose that we have a case capsules or something like that, which we have every monthly once online, and where we can have all the people across India joining in. And then a workshop. This is something that I'm developing, where we have a hands-on training, how to do a biopsy, what are the various FNACs models, what is incisional biopsy, external biopsy, what are the different things that you need to do, how to do an oral examinations, what are the various screening methodologies. So this is something that I'm developing as a hands-on training for the dental people. And even up to that, how to do a suturing, what are the suture and knots, tying of knots and everything. So this is what we are developing. Then the tobacco courses, of course, I would request everyone to encourage their students, whoever is dealing in oral cancers and head and neck cancers, they should be at least be trained at OCTC or a CTCS, so that they know how to help their future patients to quit tobacco. And the conferences, of course, this is a part of the conference, Oral E-Conclave, and that is there in the April, and the Tobacco Con, which is specifically on tobacco cessation. And I'm glad that FHN has already given me a message that they will be part of it. So this is something that we are there, and Oral Cancer Information and Screening App, which we have already developed, and which Dr. Shomesh has been putting it, that we developed it further and make it more robust as a screening app for oral cancers. Internship programs. This is something that I wanted to put, that if we have various centers across India who can give for a few, maybe a month internship program to the students who would be interested in the dental colleges nearby. Then the oral care and screening at tobacco cessation centers. This is the dream project that I want to have, that everywhere, every center, every oncology center should have a oral care and screening tobacco cessation centers, as I have put it there. And camps and workshops, we train the tobacco marshals, we train the ambassadors, all these people, they can do the individual public workshops. For a oncologist, it may be very difficult. He may do 1 or 2 workshops in a year, but if we have tobacco marshals doing it, it becomes easier. Of course, IEC materials, we have already developed it. So these are some of that Oral Oncology Connect program that I had thought, that I visualized, and I hope we can discuss further on that, and we can involve everyone into that. Thank you so much. And I think, Shruti, you can stop sharing. So it is open for Prathamesh, Dr. Alok, Dr. Somesh, and of course others who are there in the as spectators to think, rethink, and then maybe we can get back to it. So I think Dr.
Yeah, just
Somesh,
another 2 minutes. So we'll just have 2 minutes. If anybody would like to say something, please unmute yourself. I'm allowing to unmute, and you can let us know your thoughts, and then we close the meeting.
Hello, myself Dr. Shipra Deshpande. Yes, Shruti ma'am.
Congratulations to you.
Congratulations for winning the scholarship.
Thank you. Actually, I'm pursuing my PhD at Government Dental College, Nagpur. And I have taken my research topic as a training for PSC workers in early detection of oral cancer and pre-cancer in a rural area.
This is a very important thing that you have taken. I think very, very important. I think something that needs to be highlighted, and we need to work on that. And definitely we can work together. Shipra, we can definitely talk about it and work together.
I want to call you, and I want your guidance.
Yeah, of course. Now that you will be doing a CTCS, so you will be part of our program. You will be part of ICanCaRe as a certified tobacco cessation specialist. And of course, we will be there. And of course, as I've said, Dr. Somesh and all of us would be there to guide. Definitely.
Thank you very much, sir.
And we have got a lot of people in Bombay, I think Dr. Prathamesh, so many people are there in Bombay who can be very close. See, we are all team. We need to just focus on that, and we will work and we will discuss it further. Thank you so much, Supra, for being part of it. Thank you.
Thank you very much, sir.
Anyone else who wants to? Monish, you wanted to say something? Monish, Dr. Monish. I think we call it a day, and thank you, everyone. Somesh bhai. Thank you. आपको कुछ बोलना है? Informal. Now it's all informal.
Yeah, stop the recording.
Yeah, I think we had a very nice time. People sitting on a Sunday evening continuously. I think that's the kind of encouragement that we need.
Yeah, bilkul. And a lot of people are still there, almost कितने हैं अभी 53 लोग हैं. अब मेरे को लग रहा है 53 लोग ने जो है.
Yeah, maybe next time we can modify the program structure so that the audience can also speak a little in between it.
Yeah.
See what we can do.
Definitely. Chaliye, thank you.
Okay, then, thank you, everyone. Join the community page to stay tuned to all the programs at ICanCaRe and other associations. Have a great Sunday. Have a great weekend ahead. Enjoy the summer holidays. Thank you so much. Have a great time. Thank you, everyone. Bye-bye. Take care.
Welcome. And all of you, welcome to the Tobacco Con in July.
Yeah, please do join. We'll see you again in July for Tobacco Con, the International E-Conclave on Tobacco Cessation. So till then, have a great time. Have a lovely Sunday. Take care. Bye-bye. Have a great